Hey, welcome to the BCoD member forum. My name is Catherine Vargas. For all of you who don't know me, this is going to be for cracking the complex cases. And so let's get right into it, since we're kind of already on a late start. First things first, a couple of housekeeping things. We have the BCoD conference coming up. That's going to be November 6th through 8th of this year at the new Omni Fort Lauderdale Hotel. If you guys haven't seen it, you got to check it out. It is a gorgeous hotel. So we have the all access badge for $49.99, and that includes breakfast, lunches, reception. Let's see, the education sessions and valuable networking. We also have a $50 credit to use at the Omni when you register and book in the BCoD room block. And so, let's see here. All right, and next thing up, we do have the support tools. So we have, oh, sorry, you're scrolling too high, David. There we go. We have the employee support memo, scholarship application, and multi-attendance discount for practice. So if you have anybody that you know that has one or more people going from the same practice, they get that group discount. So don't forget to mention that. And then the why attend, of course, is to reduce the therapy delays, minimize insurance denials, and improve patient satisfaction. So all good reasons for, offices to hear about this great conference to really build on their skill set. And then you have the unmatched takeaways, the tools that we use every day, and absolutely priceless networking with the peers. And that's across the country. So it's pretty awesome. All right. And now we have the call for speakers. So for all of you who are interested in going up on stage and speaking in front of all these people, it's actually pretty awesome. It's not as scary as it seems. But we do have a couple of topics quite a few topics that we're looking for experts on. So we have the Medicare, Medicaid, Emma. And Emma's a big one, especially for those like me who don't use that in our practice and just kind of want to hear the feedback on, the people who are using it. Just so maybe we can try to bridge the gap there and talk about some of the unfortunate circumstances in some practices that are struggling, and then some that are having successes. We'd love to hear any of you who feel like you are an expert in that topic. Of course, how to avoid burnout. We have tough cases, skin color, insurance formulary, and as you can see, all the many. And so why would you want to present? Well, you get a complimentary registration. You'd be recognized as, sorry, I can't see all this, an authority in your field to enhance your personal brand and to share valuable insight with peers. And I can tell you all from personal experience, last year being my very first year with BCoD, and being the very first time I spoke at a national conference for dermatology, it did actually open up a lot of networking doors. I got, opportunities to learn more about different, procedures and different medications with some of the, the big pharma brands. And so it does definitely grow your networking. So if anybody does want to be a speaker, I'm guessing that we would just, follow the instructions. I believe there might have been an email on this that Kristen sent, but I'm sure if you reach out to her or any of us, we can go ahead and pass that along. But yeah, don't be shy, guys. All right. So now moving into our hard case. So for this one, this is actually for a off-label use for Rinvoq. Rinvoq is typically a fairly easy medication to get approved, but in our practice, we do have a few providers that they do scribe for pediatrics, and they do like to use this medication off-label. One of them being the liquid version, or where in this case, it's, below the 12-year-old FDA approved age at a 9-year-old. So it's a 9-year-old female patient. Her diagnosis is PSA, and the insurance is Cigna. So with that said, Cigna can be pretty up there with some of the other, nitpicky insurances. What it means is they kind of really stick to the FDA, and I don't know how much that falls in line with AI and automatic denials. But what I discovered in two of my cases, both Rinvoq, was that if I sent a letter of medical necessity originally with the first submission, there was not an automatic denial. It was actually an approval within 24 hours. So this is one of those cases where they actually responded right away. And so I found that very useful. So why is this off-label? So we have, of course, the FDA-approved PSA formulation for tablets is only for adults. It's not even FDA-approved for for pediatrics. And then we have the pediatric PSA approval that only applies to the Rinvoq liquid, not tablets. And this patient is 12 years old. So you have three different things that are kind of, you know, hitting there on, off label. So you got to kind of speak to those right away. So you have the PSA, chronic inflammatory symptoms. We have the EN with intermittent fevers and systemic inflammation. Crohn's disease, there's an overlap with inflammatory patterns. We have the HS type lesions. So these are all things that were noted in the patient's chart that I was able to simply click and copy and paste and type that into my chat GPT without violating any type of HIPAA. And with just a few sentences, it was able to list them all in this order. I mean, I'm obviously not knowing what every one of these things means. I'm not a doctor, but it's going to go ahead and format that so that it's easy for the insurance companies to be able to read and determine if this is, really a drug that's going to be, helpful to the patient. And so, of course, she still has, the persistent 7 to 10 itch. That's extremely important that you might, especially with these off labels, that you mention what the NRS itch score is. We have the, all these different scoring tools that we can use that are definitely going to be helping, helping the patient to our advantage in getting them approved. You want to mention quality of life. So you have symptoms that are impairing sleep. We have school function, and of course the daily comfort. And in a pediatric that's 9 years old, it's already difficult for a 9-year-old to sit in class and do their homework and stay focused. You layer that with all these additional symptoms they're experiencing, and then you have a real problem. And it just doesn't affect the patient itself. When you have a 9-year-old, it affects the whole family. It affects the parents, it affects siblings. And so it's kind of like an all around. So some of those things are crucial to put in these letters for medical necessity. All right. And so going to the patient's treatment history. For a 9-year-old, this is one of those patients. I mean, as you can see, this poor girl, she's used it all pretty much. I mean, at 9, she's already had a series of medications, including Stelara, Humira, Otezla, methotrexate, topicals, Zoryve, Vitama, antibiotics. So all of these, this reflects a failure of TNF inhibitors. We have the IL-12 and 23 inhibitor and PDE4 inhibitor and multiple topical agents. So you can see we're kind of listing all the alternatives that may, be thrown back at us with, hey, try this step therapy first. Where you have to really make your case in why this medication, Rinvoq, and it being a tablet, is going to be most effective. All right. And so moving on to the current symptoms and findings. So for this patient, they had persistent psoriatic plaques behind their ears and scalps. And because, she's a little girl, she had longer hair, this is really a point to hit on because as a little girl having those behind their ears, getting their hair brushed and combed on a daily basis, just typical hygiene things, you're going to have that extra irritation. We have the recurrent inflammatory cysts, the ongoing pruritus, as we mentioned, it's 7 out of 10. And then we have objective evidence of inflammatory activity despite Remicade. Now you have the rheumatology, the immunology components, and they're being co-managed. And then you can see dermatology manages the psoriatic arthritis side of things. Sorry, my phone's telling me I'm too close. Here we go. All right. And so, on to the discussion points. Has anyone had any success with Rinvoq in getting approved for PSA, particularly in patients under 12? Going once, going twice? Yeah, it's not.
Oh,
Go ahead.
not particularly Rinvoq in PSA under 12, but Rinvoq off label for adult patient with lichen. It's the alopecia one for the scalp.
Ah, okay. How did you
Oh.
get that approved?
I fought very hard with the insurance company, but my provider had documentation from NIH that we sent up with the prior auth and everything. um, to the insurance company, and they actually approved it with that documentation, that article that she had, and that's how we were able to get it approved.
And I love that you hit on that point because with us, here with the Medicaid, I think with most Medicaid plans, in particular, and Medicare, they want to see the documentation where it's like medically acclaimed references to support the use. And so in our case here in Nevada, it's automatic. They require at least two. And
Hmm.
so I didn't mention before, but I did include that with my letter of medical necessity. So you're kind of hitting on all the requirements and what's being asked before they have to ask you. So I like
Yeah.
that. Unfortunately, you have to fight sometimes, but
Yeah.
I'm sure.
Like we did biopsies and everything and still sent those two just to prove that she had it because nothing was working for her. And we got it approved and now she's on it and she's doing better.
And that's what matters. The outcomes, are what really matters for these patients. And, they're lucky to have people who can, point out these things to the insurance companies and get them the drugs that they need. So awesome. Does
Yeah.
anybody else have any like in cases, not necessarily with Rinvoq, but kind of speaking to off-label with age and, for alternative uses with being prescribed by another type of provider?
I have a Humira off label that I was able to get approved. Um, we had a patient, she came in with like a necrosis type skin disease. I can't even remember the name of it. But the FDA approved medication she couldn't be on because she has kidney failure. And there is no other medication approved to treat this condition. And so we were able to find case studies that supported the Humira, has shown in other patients with similar situations to improve the patient's skin and get rid of the condition and everything. And so we were able to use those case studies and journal articles and send off with a letter of medical necessity, like the patient can't use the FDA approved, but we have evidence that shows that this does work and has been used in other patients. And so we were able to get that approved immediately, no fight from insurance, which was kind of shocking, with it being off label, but they listened to the letter of recommendation, they read the articles, and so we got immediate approval for her, and she's doing fantastic. Her skin has healed, and this all the lesions are closed. So
Wow. So I wonder that you're saying you basically didn't have to go through the appeal. They right off the bat approved it?
yes, yeah, it was really shocking when, because I got the fax in with the cover letter, and I was like, oh, I know who this patient is. It's for this patient, and I was like, I'm scared to open it. And so I did, and I saw that it was immediately approved. And I was like, oh, wow, like this is insane. Like this normally doesn't ever happen, even with regular patients that have FDA approved indications. Sometimes you
Yeah.
can't get an immediate approval. So it was very, very surprising. And that phone call was a wonderful phone call to make to the patient like, hey, it's been approved. I didn't have to fight this. And we get to move forward with treatment. So, especially keeping her out of the hospital because she was a hospital patient, that was like the biggest thing for us, was keeping her at home and out of the hospital where she could at least heal and be successful with her treatment.
Yeah, no, absolutely. And so maybe that's, maybe that might be the key. Like these insurance companies are having to fight back and forth, asking for all these, side things, whether it be an article, whether it be a letter of medical necessity, a statement for quality of life, a letter from the patient. It's like if we know it's going to be a difficult case and it's off label right off the bat, maybe that might be the key is don't wait until they ask for it, just send it all out and not like we're bombarding with a bunch of paperwork and, things like that, because I know I can be a little fussy like that and just send the whole med guide. But in this case, both my case and in Desiree's case, a letter of medical necessity was sent off the bat and the articles to support it for off label use. And so maybe that might be a best practice. I know I'm going to start doing that going forward. I haven't had any since this particular patient. But this did run back to back with another patient I had that we were fighting to get not only off label for age, but it was off label for the liquid. And that was because she was having, we were going to fight for the pills or the tablets. Unfortunately, she couldn't swallow pills very well. And so we fought for the liquid. We went back and forth a couple of times with dosing. And I think that was really the hangup is clarification on dosing. And then having to speak to the prescriber just to ensure, we're kind of falling in line with that patient's age and the weight. But again, it's again following up with those articles and just giving that case, especially if you have other patients that you know of in the office. Of course, without breaking HIPAA, but being able to speak to the patients who've had successful treatment with those prescribers who do like to prescribe off label to these peds or even, not necessarily peds, but anybody. So thank you, Desiree. Anybody else?
Catherine, I do have one. It's nothing that's off label necessarily, but we finally just got the approval today, which was nice to end my day. We had a new patient come into our office. We were taking over care from their RA doctor. They were on Taltz for the psoriatic arthritis. And then we prescribed them Otezla, and then their PCP prescribed them Zepbound.
Ooh.
It's a nice little combo. Um, and we actually got it from the insurance today. It was Anthem Blue Cross Blue Shield of Minnesota, and everything was approved. No bridge, no PAP, no nothing.
Wow. That's impressive, especially Blue Cross Blue Shield.
Yeah, no kidding. But it goes back to like Desiree said, and kind of like you said, where like it's all about the documentation. So we really took a lot of the charts from the primary care doctor that was initially prescribing the Zepbound, and then the RA doctor that was treating. Like we took all of their notes and we really bombarded the insurance and said, this is why the patient is on this, and Otezla's coming into play from us because like we're treating the psoriasis portion and we're just taking over care because really they kind of all fall in the derm world except for Zepbound. So we kind of shoved our way in there.
Well, sometimes you got to do that. But I think too, um, especially when it's very easy for whoever is reviewing these special cases to see, okay, well, did they get the two articles? Oh, yep, check, they do that. Okay, is it affecting quality of life? And it's labeled very easily for the, whoever's reviewing to see. I think it just kind of gives them little butterflies like, all right, somebody knows how to do it right, because we're making their job easier too, to be able to not have to search for that information on their own, but to be, to point it out and say, here, this is why. This is why. So great
Right,
job, Dan.
100%.
All right. How about anybody else? I know we all have a whole bunch of cases. Not a whole lot of time. We have like 7 minutes left, but anyone else want to share? Okay. All right.
So
Well,
I was gonna say
oh,
I put mine into the chat. I don't know if everyone can see it, but I had an insurance company tell me that the patient's Dupixent failure wasn't a good enough failure.
what?
Yeah, so basically the notes were
What?
super clear. Like we sent the prior authorization over to the insurance company and I was like, "Oh, this is slam dunk. This is great. Really easy. Their criteria is that the patient needs to try and fail Dupixent before they get access to another medication." So it was Nimluvio that we were getting them on. We had the
That
patient inject in the office to make sure she could like use it and that she would do well with it. So that was even in the note saying that she would do well with Nimluvio, and they still denied it. They were like, we need a letter of medical necessity that states that the patient brought the medication to room temperature before injecting, that she used numbing creams before injecting, be super clear
okay.
on how
So,
she failed it. I was like, this is wrong on so many levels.
hey Amy, I've dealt with this before with um Dupixent and Nimluvio switching
Mhm.
over. So, are you filling out the start form or are you doing everything online?
So it was an insurance company. It's a local insurance company, and it was just the payer. So I did the enrollment form directly to Nimluvio or to the specialty pharmacy, but did their prior authorization on a paper form because it's a local plan that isn't even on Cover My Meds.
Okay.
Yeah.
So, what specialty pharmacy?
So they'll probably end up I'll probably choose like CVS or Credo or any of them because I think they actually have to fill it like a specific one.
Like
But
a
with
specific
Nimluvio,
one?
they're not. yeah, they're not going
Okay.
to be able to. But so
So,
the pushback was just, it was just from the insurance company, which was wild. So when I spoke to them,
yeah.
I was like, this is so wrong. You can't do this. Like a failure is a failure. You can't
Yeah.
specify how they fail.
So you send it to a credo. A credo should be able to take those notes and send it to, like, they'll at their pharmacy, because where I'm at, we use Sendera, and Sendera is great. They handle all that, and they would have just looked at all that and, okay, you failed it, and then just
Oh yeah, yeah. No, it was such a simple, it was a baffling conversation that I even had to have with the insurance company. I just couldn't even
exactly.
believe that they called and even asked that question. And so I literally said to the guy on the phone, I was like, you need to go back to your medical director. I was like, I'll write the letter for you. No, no problem. Not a big deal.
No
I'll do
problem.
whatever
Yeah,
you need me to
that's
do. I was like, but you need to go back to the medical director and let them know that this conversation is completely unethical and you can't
it
be
is
doing
such a
this.
waste of
And
time.
then I
Yes.
hung up, and then he called me back not even 10 minutes later and was like, we don't need a letter. The patient's approved.
Oh
Yeah, I
God.
was gonna say you even putting it in writing, like back to them in facts, and say, "Hey, what's your legal basis for this? Where's the measurement? Because it seems like you're in violation of the patient's rights."
Yeah,
Something was
it
wrong
was
there.
almost like they didn't even understand that they were wrong until I like repeated it back to them and made them hear themselves. And then the guy on the phone was like, "Oh,
Yeah,
you know
you're
what?
wrong.
Yeah,"
Yeah,
he was like,
sorry about that.
why don't you just why don't you write that letter and I'll get back to you." And I was like, "Yeah, you do that."
Oh
Mm-mm-mm.
boy. Well, good thing you fought for the patient and didn't take no for an answer. I mean, that's kind of what our job is, right? We're supposed to look at
I
these
feel like that's what
things.
we have to do.
Yeah, every
For
time. And it's
sure.
like, I don't know how many other biologic coordinators, MAs, those who are handling biologic denials, how often or how much time they have to spend on looking through the denials, because I mean they're complete BS, some of them. It's just like, wow, who reviewed this? And I think
Hmm.
that's where the gap comes with AI and intelligent, you know systems like Cover My Meds, who use all these things, and then you have the actual reviewers who most of the time have nothing to do with dermatology, which is also crazy. Like how can you
So
get
valid.
a medical professional to give me a denial based on, wherever they're from? But all
Hmm.
right.
Has
Well,
it
guys,
given
thank
to
you
me
for
by a podiatrist. It's insane.
Right?
yes.
Oh, that's
I
my
mean,
favorite.
but doctors.
Podiatrists, OBGYNs, pediatricians.
Yeah, it's insane.
Yeah, that's the story of our lives, right?
Yep.
Well, we're getting kind of close on time here, guys. I just want to kind of go over a little bit on what's upcoming. We got some exciting webinars coming up. Sorry, my screen's super duper small, so I have to look at the printout I have here. But we have the BCoD member forum for next level skills, and that's going to be Tuesday, March 10th. Am I saying these right, David? Am I seeing them on my page? Because they're so small and I don't have my glasses on.
Yeah, no, you're
Yeah,
you're
you're
good.
accurate.
Okay, cool. And then we have the series check, or the check-in series, and that one's going to be April the 14th. And then we have the cracking complex cases, which is going to be May the 12th. Forgive me, I cannot read the rest of it, guys, because I don't have my glasses. But I do want to say the invites did get sent out, and I know I have missed, putting them in because I put off opening some of the emails at some point. I've tried to make it a point to not do that, and as soon as Kristen sends it, I'm just clicking yes. Because easy to forget. Like, oh, I'll come back to that later. I'll have to check my calendar. Just click yes. And if you can't make it later, then you can uninvite yourself. But just so you don't forget about the calls. You guys are all pretty good about it though. All right. Well, that's kind of the end of what I have. Does anybody else have any feedback, anything they want to add before we close out? All right. Well, thanks again, guys, for joining this series. And I hope you all, got something to take back that's valuable to help your patients. Yeah, let's go get them. You guys all have a great night.
Thanks,
Thank
Catherine.
you,
Thank
everyone.
you. You have a great night.
Thank you.
Thanks.
Bye bye.
Thanks. Bye.
Bye.